Good afternoon, ladies and gentlemen. So, you're welcome to the Symposium in Refractive Surgery for the State Conference. And I would like to have my discussants, Dr. K. Mahadevan, sir, and Dr. Narayanan Kutty, sir, here. So, as we all know, Dr. Narayanan Kutty has been a pioneer in refractive surgery in the state of Kerala, along with Dr. Tony Fernandez. And Dr. Mahadevan has a keen interest in the procedure and he promotes it. I'm Dr. Swapna Nair. I'm a refractive surgeon for the past around 17 years, and I do both lens-based as well as cornea-based procedure. We have a very good faculty over here, consisting of Dr. Shaji Hussain, Dr. Sujit Nayanar, Dr. Tushar Agarwal, and Dr. Sri Lakshmi. So, without much delay, shall I ask Dr. Shaji Hussain to start his presentation? He'll be talking on how to choose your patient and how to see the warning signs regarding the profile of the patient who is eligible for refractive surgery.
Good afternoon, everyone. As you know, the topic as a whole is about refractive surgery, and my role is to customize these refractive surgeries based on patient profile. To begin with, refractive surgery, it's moving? Yeah, okay. So to begin with refractive surgery, there are two mainly based, laser-based and non-laser based. Laser-based was PRK photorefractive keratectomy and laser in situ keratomiliosis. The non-laser based systems are intraocular columnar lenses. It's moving without me pressing. It's going. No. Sorry about that. No. Okay, so the absolute contraindications are animation timing, is it somewhere? Okay. The absolute contraindications are when you have a okay, thank you. Okay, the absolute contraindications would be when you have an unstable refraction, and if you have corneal abnormalities like corneal ectasias, corneal vascularizations or interstitial keratitis, and if the cornea is not adequately thick for the resultant ablation, if the patient has, it's moving fast. Okay. Oh, okay. Double click that. This one. It's fine. Okay. So uncontrolled glaucomas, autoimmune corneal uncontrolled autoimmune diseases, and when patients have lid margin diseases, or patients who have uncontrolled depression and high patient expectations. So the relative contraindications would be when the patient is patient is having monoclarity, excessively steep or flat corneas, abnormal corneal topographies, significant irregular astigmatism, history of uveitis, diabetes mellitus, pregnancy or lactation, and age under 21 years. So the refractive errors that should be corrected are with regard to laser based procedures when the powers are less than -6 diopters, and we can between -6 to 8 we can use laser based as well as intraocular columnar lenses, and when the powers are above 8 we can usually opt for a intraocular columnar lenses, and because there are higher possibilities of post LASIK ectasias or regression of the powers. And if the age is above 40, we can also recommend clear lens extractions, and here the EDOF lenses are doing a great job. In hyperopes, the power recommended would be a power less than +3, and make sure the orthoptic evaluations are very well taken care of. Otherwise, usually the +3 powers patients regress quite often. So in case of LASIK, what are the parameters we usually keep in mind? We know that there is a laser, examer laser is being used and a flap being elevated, and the stromal is being ablated and the flap is placed back. So the first thing we keep in mind is the RST, that is the residual stromal thickness, and the first thing is the total corneal thickness. We know this is the corneal thickness, and this is the flap that is being elevated, and this is the stroma that is being ablated, and this is the residual stromal thickness that remains. So I usually keep an RST of 300 microns as a cutoff, and the flap thickness that I usually take is 130 microns. If it is the RST is not meeting up to that, I make my flaps thinner to 110 microns or 90 microns. With regard to stromal ablation, it depends on how much power is being ablated. That can be taken up from this from the Excel sheet that is provided by the machines. Like if it is -0.5, this is the micron that is being ablated. If it is -1, 27 microns, and this is the cylinder. So accordingly, we will know how much of stroma is being ablated. Now this is for different optic zones, and now as the powers are going on the higher side, the amount of ablation that is are also increasing, and accordingly the RST will be decreasing. So when you have the RST is not meeting up, then we'll make the flaps more thinner, and we can also change the optic zones based from 6 and 6.5 usually based on the pupil size, mesopic pupil size. Usually in Indian patients we keep it at 6, and if Middle East patients they have a larger mesopic pupil size, we make it 6.5. The next thing we have to keep in mind after the residual stromal thickness would be the post-op K, and we know the corneal usually having a curvature between 42 to 46, and in post-LASIK we flatten it up, and the cornea should not get more flatter than 34 microns. The next is the flat. We should not be using a keratome based procedures on a flat corneas that is less than 40, and also on steep corneas that is more than 48 diopters, because in flat corneas we can highly get with a keratome we can get a free flap. For steep corneas we can get a buttonhole. And the next thing we have to keep in mind is the percentage of tissue that is being ablated, and here that is telling us the amount of cornea that is being weakened by raising a flap and by doing the stromal ablation. The cornea that remains should definitely be more than 40%. It should not be the area weakened should not be more than 40%, because this can result in post LASIK ectasias. So the numbers to be remembered for RST would be 300. It is currently according to the preferred practice patterns in AO it is 250 now, and PTA is 40 and 34 for a flat case. Now let's say if there is a Google app that is being I have made to calculate all this in one go, and we can just enter the power and it will just tell us how much is the PTA, RST and post-op case. can be easily calculated by the optometrists themselves. So if the patient is not fit for LASIK, the next thing in option we would have is PRK, photorefractive keratectomy, and here it is nothing but we are debriding the corneal epithelium, ablating and placing a contact lens, and here the RST I usually keep is around 400 microns. We will have a little more stroma to play with in PRK. So these are the two refractive. Third one would be the ICL, and the next one would be the clear lens extraction. So to talk about the cutoff, I usually keep as I see depth in ICL is 2.8 microns and white to white is 10.65. And with regard to clear lens extraction, clear lens extraction, it is nothing but we usually consider it for an age more than 40 years, and here we have the EDOF lenses, and with regard to application of multifocal lenses can be considered all based on the higher order aberrations and the patient's need. And with that, thank you.
Thank you, Dr. Shaji. That was quite comprehensive, and I'm sorry for the initial hitches that you had to face. Anyway, it was good work under tremendous pressure. In this respect, I just wanted to ask Narayan Kutte sir, because he is someone maybe amongst the entire crowd who has been doing refractive surgery for the longest time, and you have seen the entire, wave come and, change. So, in brief, what would be the most remarkable change that you have seen? I mean, is it the thinning of the flaps, or is it the lessening of ectasia, or what, in your words, would be the most remarkable change that has happened in refractive surgery?
Remarkable change is the case of flap only. Because unless you are not very much experienced, the chance of getting complication when you use a motor for the flap making, it is more. So that is because a less number of complications are there. The one thing, that practical problem that we face is a major portion of LASIK people, they are either mainly people going for employment or people who are getting married. So that age is 18 to 21. So in our institution, we have made the cutoff at 18 years, not 21. Because of that, the demand, and if the power is stable for the previous 2 years without any change, I don't find any problem by taking persons above the age of 18. And in our institution, we also go for LASIK up to -8, provided there is adequate thickness of the cornea, because 300 micron definitely will keep as residual cornea.
And I think one parameter should be the K values also, if they are not too flattened by the laser.
K value is a very important thing when you are using motor, keratome.
I think Dr. Shaji explained that quite well. Any questions for Dr. Shaji? I next request Dr. Sujit to carry on with his presentation on one of the most dreaded complications of laser vision correction, namely ectasia.
Thank you. Thank you, and very good afternoon to all of you. I'll be speaking on the tools to prevent and manage post-refractive surgery keratectasia. As Dr. Sapna told, it is one of the most unwanted complications that we have for the refractive surgery. The incidence roughly quoted in literature is 0.02 to 0.6%. And it varies from various types of procedures like PRK and LASIK and even SMILE. The ectasia was found to be, the key factor is around 4.5 times more likely after LASIK than PRK. And interestingly, this article, this was showing this picture in which you can see the yellow lines are those with the SMILE, which was actually introduced as a better refinement of the laser procedure to prevent. One of the motive was to prevent ectasia, but you can see over the years the ectasia numbers in SMILE is also increasing. So the incidence is varying. It is different in various procedures. We are not sure about various risk factors that is involved, and there is some underreporting also that's happening. So commonly identified pre-op risk factors, most of them Dr. Shaji already mentioned. These are topographic variations, thinness pachymetry, pre-op keratometry, the PTA value, ERSS score, residual stromal bed. Most of them we normally look into. Still, it is told that up to 6% of patients can be picked. Retrospectively, when they look at those who had ectasia, at least 6% was missed during the pre-op investigation stage. So it includes, our suspicion should start from the patient's history, very early age, like what Sir told. Sometimes they are actually waiting for their 18th birthday because they know after 18 years we can do it. It's just not the age. We are also looking at the stability of the refractive error, which from history most of the time we won't be getting. Progressive myopia, any changing or new astigmatism as per the previous history. The disparity in the subjective and objective astigmatism, allergic background, chronic ocular inflammation, any association with systemic diseases like PCOD, thyroid dysfunction, vitamin D deficiency is also found to have some relation with this ectasia, some Down syndrome. All these things should make us think of a suspicion of that candidate, whether he can go in for a bad result. Those who regularly do refractive surgery, at one look, this is looking a normal scan to me, and refractive error is also not that much, just two diopters of cylinder. But I refused laser refractive surgery for this patient just because his younger sister was treated by me for keratoconus, and the C3R was done. So I was little scared, just immediate sibling, having a keratoconus, I would not touch this eye, at least waiting for next few years. So there are certain factors we know as identified risk factors. There are many factors which we don't know. So respect to Dr. Yaron Rabinowitz is a very common name in the field of keratoconus and topography. He passed away almost 20 days back, just 4 days before the World Keratoconus Day. He had put out these 10 most famous topographic patterns. This is commonly screened in our routine preoperative screening. He, along with McDonald, has put out some indices also for screening, which includes the central keratometry value, inferior superior value, and the skewing. But there are certain subtle things which we should not miss, or we should try to look for in suspicious cases especially. Not just the central thickness or the thinness pachymetry. We should also look for the coordinates of the central thinness point or the thinnest point. The Y coordinate is more important. Whether it's going down and temporally is one thing which you should look for. Another thing is the difference between the thinnest as well as the thinnest point with the apex. Also, pachymetry screens, most of these higher-end topography machines have these things incorporated into it. So you have to, the pachymetry, just not the pachymetry value, the progression of the pachymetry from the center to the periphery is also very important. And there are graphs and there are color-coded maps also to make evaluation much easier. So when these lines come out of this graph, you have to be really suspicious. Next important, other than the pachymetry, would be the posterior elevation maps, which we know the shapes, island shape and tongue shape are quite suspicious. We have to also look for the values and also the difference in the value between the elevation back and the front at the thinnest point. So these are all subtle things which may be adding some value to our regular screening points. After that, we have this ectasia risk scoring system. Most of these points are all same, but they have put it into one screening system or one scoring system, and to make things easy for us. PTA has already been explained. Anything more than 40% is strongly associated with development of ectasia. Bellin-Ambrosio scale, again, pentacam is, most pentacams have this attachment, and it's quite good screening tool for ectasia. Epithelial mapping is one newer advancement in the last few years, where you can look for a donut shape pattern of epithelial remodeling, which can be a clue for early keratoconus. But some fallacies also are there for these types of indices. For example, this I've taken it from an article. This patient was screened by Bellin and was found to be normal, but post-operatively he or she developed ectasia. So the bad criteria, Boolean amplitude display criteria has got a sensitivity of 80 to 87, sensitivity of 80% and specificity of almost 78%, but still it's not 100%. So this one patient of mine where I have burned my fingers, it's only one eye is involved. He has come for an recruitment. I didn't have a previous history of his refraction. Only one eye, 0.75 cylinder. There is some skewing, some yellow flags, which I ignored. In just 3 weeks, he came with ectasia. Much to my surprise, because in 1 month time, he was having his recruitment. In I thought it may be some epithelial remodeling, but in 5 weeks time, it worsened. Now, I had a bad time talking with the patient that I cannot help him to go for the recruitment, but I will have to definitely help him to regain his vision. Comparison map also shows clear-cut ectasia in this. I thought whether it could be epithelial remodeling. I did with and without epithelium. After removing the epithelium, I did a topography. There was actually worsening of the ectasia part. Take 2 more slides. So post cross-linking, actually he improved. He improved and he regained his vision 6/6 part and he got selected into police department. So post-operative risk factors also needs to be looked into, because it's not always, any ectasia may not be our missing or our mistakes. It can be something that happened, any event that happened after the laser refractive surgery, like pregnancy, allergic rubbing, PCOD, and even adenoviral keratoconjunctivitis is supposed to increase the apoptosis of the keratocytes. So when is ectasia suspected? It's earlier presentation, up to 2 weeks also it can present, like in this case, or late presentation. You can have progressive drop in the uncorrected as well as the best corrected vision, and with topography evaluation showing signs of ectasia. But definitely the regression should be ruled out, and it's quite easy to rule out the regression because the keratometry you can see the central flattening. Once it is diagnosed, the options that is in your hands are stopping the progression with corneal collagen cross-linking, or even if it is a very early case, you can think of doing a topo-guided PRK along with cross-linking. Corneal rings generally gives good results for cases with ectasia, and if it is a last resort, you can think of DALC or a corneal transplant procedure. Cross-linking specifically in post-laxic ectasia, there is a controversy whether it is as good as in a keratoconus, but special concern we need to look for is, generally it's a post already treated eye, generally they have a lower pachymetry and you may have to use a thin cornea protocol. And so it's time up, so I'll just summarize. So all attempt is to prevent the ectasia. Topographic indices remains the best reliable investigation. Most important determinant remains the RSB, the depth of ablation as well as the age. Various indices gives supplementary evidences only. Eye rubbing and post-operative risk factors also should be given due importance. Timely suspicion, early diagnosis and management can reduce a progressive damage, and unidentified factors still remain as hidden risk factors for ectasia. Thank you so much.
Thank you, Dr. Sujit. I had a question regarding that patient because you have actually aroused our curiosity so much. So what was...
show up that.
Yeah, please do. What was the thinnest pachymetry reading there, and what was the dioptric power corrected?
0.75. 0.75 cylinder. He was 6/9 parts, just short of his recruitment criteria of 6/6. I normally don't take up, but obviously they do pressurize, and if it's for a job, we tend to sometime.
And was it matching the topographic cylinder and the acceptance cylinder?
I think topographic was 1 point. Yes, it was 0.9. The manifest was 0.75.
And the pachymetry, the thinnest?
Pachymetry thinnest was 4, I think it's 480 range, 480, 498 or 488, I'm not very sure.
Okay, so overall it is, what, do you have any comments on this, Dr. Tushar? Because can we have some? Like we
Yeah, so
yeah, we're just trying to analyze.
so aside from
how
the
such things
obviously PTA is not going to be an issue in this particular patient, but I think depending on the practice, we at RP Center keep 480 as the absolute sort of final cutoff. If it's 480, even a micron below 480, we don't touch the cornea with any laser. But as Sujit said, it was like in that borderline group. But the other thing which I have seen personally from the referred cases and from whichever cases we have had ectasias, it's the most unexpected patients who who get ectasia. I mean, I have never seen a patient with high sort of refractive errors getting ectasia actually. Whatever ectasia I have seen, it's been in the low to moderate group of myopia. I've never seen anything happening like this fast or in this low degrees of refractive error. But I've definitely seen ectasias presenting with having been treated for -1. So there are factors which are sort of right now which are not very clear to us. What is causing the patient got other eye was also treated?
No, other eye was
Okay.
6/6 unaided.
Okay.
Actually.
So as I said, the factors which are causing ectasia, I think right now beyond our understanding at this point or beyond our reach. And the best thing we can do from the medical legal point of view is having a complete documentation and our SOPs in place.
In the same vein, I have had a patient who had equal powers corrected in both eyes, and like you said,
Yes.
it's never very high. It's -2.5 or
yes,
-3
it's 2.5.
most of the
Somehow
time.
it's the most common thing is 2.5 range.
One eye went into ectasia, the other didn't.
Yes.
So, I mean, how do you account for that? So, I mean, does it put a fear in novice surgeon's mind that, you know,
No, I
you
think
don't
I
know
think
what
as
you're
long as
dealing
your SOPs are strong and your practice is ethical, I think there is nothing to fear about. But your SOPs need to be strong. Like you have to have very strict criterias for. I mean, there should be yes and no criterias. No should mean no in refractive surgery. You can't change your goalpost in refractive surgeries.
No, I'm also surprised at the way it responded to C3R. It is almost normalized now. See?
Yeah, that is also.
So it's very
Something unusual.
Fluctuating, yeah.
I mean, I've never seen getting an ectasia in 5 weeks and then responding so quickly to
in
CXL.
literature the shortest is 2 weeks.
Okay.
Actually, I searched after this.
Yes, absolutely. No, I'm not saying that it's not
Yes,
accurate, but I'm saying that it's surprising. But at the same time, if it is responded to CXL, I think we'll definitely like to have how the patient behaves in the final period.
Would you prophylactically do a CXL for the other eye?
We'll have to think in that line if this continues.
Yes.
Yeah. What was the age of this patient?
He was 22, 23, that age.
Could you enumerate the SOP that, like
He's
for the
22.
benefit of the audience, some salient points that have to be, fixed before taking up any patient for laser refractive surgery? Maybe the
See,
5
obviously,
most-
one is I normally look at there is criteria for the pachymetry, the RSB and all. I also look at I slightly differ from what Sir told. I will not jump into a laser procedure at 18 if it is for a cosmetic thing. I will ask them to wait for, because this 18 thing is mainly, I may take it as a criteria only if it is a recruitment thing. I've seen those who have done at 18, most of them comes with some sort of regression later on, especially females after the childbearing age, they tend to come. They are still not stable. That's what I believe. 480, 300, RSB, these are all standard things. But see, in this case, even if it is 480, what is the amount of tissue that I am going to ablate? That is what I thought. And if it's giving someone a job, he's otherwise 6/6 in the left eye. So there is some emotional things coming in between. That is, and that's where we land in problems.
Any comments?
Should you not examine for systemic disorders, dormant, high ESR?
So if there is any sort of
colon vascular-
suspicion or any sort of anything in the history, see, to be very frank, this is my second case of ectasia. First case of ectasia was 10 years back. Dr. Priya may be remembering that case. He had a skin disease. Which I overlooked actually. And that also, actually that patient came with ectasia within 3 months, both eyes. So, probably.
Yeah. So I think we should carry on that discussion, So next, I'd like to invite Dr. Tushar, Dr. Tushar Agarwal, who would be speaking on corneal lenticule extraction, current paradigms and future direction. So this is with regard to SMILE. And with regard to SMILE, before you start, I had a question. In the sense, we saw Dr. Sujit's graph, where slowly you see a progression of reports of ectasia in SMILE. So my question was, is it because SMILE was considered to be so safe that sometimes you can overlook some of the stringent criteria that we push for PRK and LASIK? Is that why it's happening?
So I'm not aware of the graph itself, but it would be good to look at the percentage A, because the numbers have gone up. You know, it was, if in India, of course, it was introduced about 3-4 years before the US. It got FDA approval in 2016, and you know, once it gets approved in US, they just fall into the latest technology. So you're talking about the absolute numbers, or you're talking about the percentage on the base? Because the base would have gone up significantly after 2016. Yes, so number of cases, absolute number you do expect, because once the technology is approved in US, their numbers are totally different than our numbers. They are very, very high. So, yeah, yes. So that sort of explains it, because you do expect the percentage. I think is the more important factor. That needs to be seen. So that was my hunch. So thank you. Thank you very much. So I'm presenting this talk on behalf of my colleague Professor Rajesh Sinha, who couldn't be here because of some personal emergency. So I actually went over this talk with him last night over the phone, and I'll try to do justice with it. So now this has been covered by the previous speakers, that initially the laser refractive surgery began with surface procedures, PRK, epi-LASIK, etc. Then the microkeratome came into picture, where a manual electric microkeratome was used to create a flap, and then the laser was done, which was called LASIK. Then we shifted to an all-laser system, where the flap also was created by the femtosecond laser, and then the ablation was done on the bed. And then finally we have landed with the SMILE, or flapless laser vision correction system. So it basically entails that you create a lenticule which accounts for the amount of refractive error. So it creates the amount. So it will separate out a tissue intrastromally by the use of a laser, which is directly proportional to the amount of refractive error which you want to correct. So you can just have some random figure for understanding that, okay, 20 microns per diopter, or 30 microns per diopter, and so the higher the refractive error, the thicker the lenticule, and you, instead of just vaporizing that tissue, you create that lenticule and you remove it through a small incision. So this, as I said, this was approved in 2016 by the FDA for myopia and myopic astigmatism. So you create the lenticule with the help of a laser, and then you have to do a manual separation, because it's not cutting. The laser is not cutting in a tangential manner. It is just creating a multitude of spots, in two different planes. So there are micro adhesions between each spot, which you have to dissect out manually, and then you have to extract it. So this was the pioneering system, the Visumax. It can create various types of incisions in the cornea. So you can actually create flaps and do a flap-based surgery also. You can do customized keratoplasty. You can do intracorneal ring segments, and then you have SMILE. So this is the geometry of the lenticule which I was referring to. So although it's a flap-less surgery, but you do need an area to access that lenticule. So in the initial part of the learning curve, we used to have a side cut of around 4 millimeters. And as you progress, you can continue to decrease the size, and you need a minimum size of 2 millimeters into the cornea to remove this central lenticule. Optical zone is 6 to 7. The rest of the parameters are similar to LASIK. So this is a short video which shows the procedure. So the docking is done with the PIS system. So what is happening is that the laser is firing, and it's cutting in two different planes. So first it cuts in the bottom plane, and then it cuts on top of it, because once a plane has been created, the laser cannot go beyond that. So you first create the posterior plane, then you cut the anterior plane, and this is all undergoing in about 15 to 20 seconds time. Following this, you open up the incision. So this is a full this incision is going through the anterior cap, and then you open this incision. We used to also use, I think this is his older video, we used to make side ports, which we have stopped. And then this is the trickiest part, and the one which involves the most of the learning curve. So now you have to separate the lenticule intracorneally, both from the posterior and the anterior side. And this is what requires the most amount of training and patience. So you first separate it from the anterior side, and then you go in below the lenticule and on top of the stromal bed, and then taking care to sort of reach the entire edges. So your goal is to now separate the lenticule completely from all sides. Now, in this particular case, I saw that you can use forceps to remove the lenticule. It can also take care of the adhesions on the side. But now, mostly once you go beyond 20-30 cases, you don't need these forceps. You just dissect the lenticule completely from the anterior and posterior side, and it can just come out with that. We normally do try to sort of unfurl the lenticule on top of the cornea. And especially if you're not sure, if you have left some part behind, you can unfurl the lenticule on the top of the cornea and just see whether you have removed the entire thing or not. This is an intraoperative sort of a slit lamp kind of thing, which is also there. You can examine the interface for any debris or any sort of left out lenticule. And finally, you can just use a wet sponge to smoothen out the area of entry. Okay. So these are a few of the initial results which were published. So in this particular study, the authors studied two groups of patients, of one consisting of mild to moderate myopia up to 5 diopters and other higher degrees of myopia. And as you can see, compared to the low to moderate myopia, where 93% patients had UCV of 6/6, only about 75% of patients beyond 7.5 had a vision of 6/6. No, sorry. Yeah. So these were more of a long-term results of 5 years, and they also concluded that this procedure is safe and efficacious. As you might have noticed, you are removing a central lenticule. So this procedure theoretically was not possible for hyperopia, and even still it's not approved for hyperopia, but people have started now working on actually treating hyperopia. If you have seen hyperopic laser vision correction, you actually need to steepen the central cornea, and you do this by removing more in the periphery rather than in the center or in an annulus form. So now people have started work on this, where the lenticule is shaped in such a manner that the center is very thin and the periphery in a ring form is quite thick. And once you remove that shaped lenticule, you can actually treat varying degrees of hyperopia. But as with all laser vision correction, hyperopic corrections, the results are suboptimal as compared to myopia. I'll take 3-4 minutes more. Couple of points about the learning curve. This has a steep learning curve as compared to LASIK. You do need about 15 to 20 cases to be quite confident. Compared to LASIK, the easier cases are those which have a higher degree of refractive errors, because the lenticule will be thicker. The smaller degrees of refractive error, you get a very thin lenticule, so you might find it actually difficult to remove. And the initial cut, you can also try a flap-based lenticle extraction in the first few cases, where you can actually lift up the entire flap and have the stromal bed to yourself, and then make the dissections. And then you can proceed to 4 mm side cut. It gives you a lot of room to move around your instrument to do the dissection. And once you are confident, you can go to lower degrees of myopia and lower degrees of refractive errors. Okay, so a couple of points. Now, the the prime problem with this technique was that when you talk about astigmatism, there is no cyclotorsion control. So if the eye rotates or intorts during the laser, there is no accounting for that, which you do have in LASIK systems. So now the newer system, which is Silk, and there is one more system, yeah. So these both have two advantages. They are using lesser amounts of energy, and also they have cyclotorsion control built in, so even higher degrees of astigmatism can be treated reliably. Previous to this, more than 1.5 diopters of astigmatism weren't very reliable enough to be treated by SMILE. And this is a similar thing. And thank you very much. I won't repeat the same things again. Thank you.
Thank you very much for the talk. It was a very nice one. You mentioned about the Silk, where you can perform the same, with the same equipment you can do the Silk.
No, I think it's some different manufacturer.
Oh.
Silk is not on the Visumax platform.
Well, the only problem, the only torsion.
And the pupil centration also.
Oh.
There is no tracking in the SMILE system. So,
Okay.
so both things are there. So you can have a pupil-centered ablation, and plus you can have cyclotorsion control. So there is no registration in the SMILE. So that was a major issue. That's why the results with especially higher degrees of astigmatism, where cyclotortion actually comes into play, is not useful.
And theoretically speaking, that the ectasia should be less in case of. But what is your experience?
Yeah. So.
Because the stability of the cornea.
So it's a question of what your true belief is. If you believe that the cutting of the moments is also responsible for ectasia, then yes, it should be. But if you see the data, why do we stress more on because why do we stress more on the bed? So the bed, the stromal bed thickness is same. The criteria are the same. The same kind of thing is there. So ectasia, I think, are theoretically similar. Of course, the major advantage is the sort of almost the non-occurrence of dry eye, which you quite often get, especially once you cross 25 years of age. In the patients, you get a lot of dry eye, and they need to be on lubricants for up to an year. So that dry eye problem is not there with SMILE at almost zero. So that's the major advantage. But ectasia, I'm not sure if there is a...
because in LASIK, because of the flap, even after 20 years, you can lift the flap, same flap.
Yes, so flap, that flap is like a permanent contact lens. Even with trivial trauma, it can come out if there is something, even a finger hits or something. So all those advantages are there in any kind of contact sports. Even army men, SMILE would be would be preferable to LASIK, because that flap even VR surgeons I have seen, a lot of times if these patients undergo VR surgery for some reason, later on the flaps come out on the table, and a lot of times they don't even realize that they have removed the flaps. They just rub it and throw the things.
That problem is not there. Still, ectasia is almost same. No, that's what I'm saying.
Yes, that's what I'm saying, because the bed is what is, I think what you're leaving on the undersurface is, I think, the most important thing. If you're leaving a thinner bed, you will have ectasia. It's not the cutting of the moments which is causing ectasia, I think.
Even otherwise, in certain cases, even the bed was more than 400 microns. Yeah. And after 4 or 5 years, patient got ectasia.
Absolutely.
So there are so many unexplored factors.
So no one has been able to correctly predict who will get ectasia. That's the biggest problem. If you look at any paper in ectasia, so many case reports perfectly, corneas of more than 600 plus, having undergone LASIK for 2.5 diopters of myopia, still getting ectasia. So there is no definite pattern which is observable or sort of identifiable that, okay, this is, and even these criteria which have been made, I'm sure, because you can't do a prospective study on this. It's almost next to impossible to do a prospective study on ectasia solely. So it's all retrospective data that once you get ectasia, then you go back looking, okay, what was wrong? What did we, or what was done actually? We have seen ectasia in a couple of patients who turned out to be hypothyroid. Now, does hypothyroidism cause ectasia? I don't think so. So those were incidental associations, and this is just a compendium. If you see the literature, it's all a compendium of anecdotal evidence that someone publishes 6 reports, someone publishes 2 reports, and then you combine all those data. So I think that's the major issue with the regarding the finding the etiology of prevention of ectasia. The attention is focused more on treatment now than on prevention. At least we can treat ectasia now. There are multiple options.
Any question? After your SMILE procedure, suppose there is a regression.
Yes.
What will be your line of action?
So
Whether you go elastic or PRK or anything.
So if the question is that if there is a regression after SMILE, what are the options? You don't go and do another SMILE. Basically, either you do a surface-based procedure or you do a LASIK. My preference, personal, would be to do a surface-based procedure after that. Simply because then you can do a topo-guided laser enhancement. And second, you don't end up with 3 interfaces then. Otherwise, you have now 3 levels of the cornea. So you have one bed, then you have an intervening stroma, then you have a LASIK flap. So I don't want that in the patient. It will definitely lead to loss of contrast. As such, their contrast is compromised after any laser. And if you create one more interface, it will create a bad contrast. So my preference would be to do a surface-based procedure if at all required. Even if there are complications, sometimes you lose suction halfway through, something like that. My preference would be to shift to a surface-based procedure at a later setting, rather than creating one more flap in that patient where there is already the interface has been created.
There is a remote chance of haze formation also.
Sorry?
Corneal haze formation for PRK. It's not a remote chance is there.
So now everyone is advocating routine use of mitomycin for all cases of PRK. So we are using mitomycin C in all cases of whenever we have to do PRK. And unless you're talking about refractive errors of more than 4 or 5 diopters, then we don't see much of the haze is not much of an issue with PRK. But I think it's coming back again. The cycle has now come back again to surface after having seen flaps and everything, flapless, this, that. Everyone has realized that LASIK, no, I am finished. So, talk is the next speaker. I'm finished. I'm just carrying on. Thank you.
Thank you.
Lenticule placement? No. Actually, in fact, Dr. Rajesh Sinha is doing a lot of work in this. He is doing lenticule placement for management of keratoconus. So he is putting shaped lenticules intrastromally in keratoconic patients. So he is creating lenticules with the help of a femtosecond laser from donor corneas, and then creating an interface in the patient, and then placing those, I think 150 micron or little more lenticules in the cornea. Dr. Namrata Sharma is doing the same with bioengineered corneas. Placement of basically you add stroma to the previously existing cornea, but I am not sure about the hyperopic correction with that. Is it working?
Next, I'll
Yeah, is there any question from the audience that needs to be addressed? Because now we'll be moving on to complications of refractive surgery, both lens-based and laser-based. So is there anything for the routine procedures that we need to elaborate before that? Okay, so I would be talking about lens-based refractive surgery complications as well as laser-based. So now laser-based in itself, because there are different types of procedures, can be flap dependent or they can be the excimer laser dependent. And flap again is further divided into whether you're taking a flap using a microkeratome or whether you're taking a flap using the femtosecond laser. So each aspect has its own complications, or whether the excimer laser by itself produces any. So all these are the intraoperative factors. Then coming to the post-operative, you can have displacements of the flap, you can have an epithelial ingrowth. So again, displacements can be early or late. So I'm not talking about the very minor complication of microstriae, which may be seen in some patients, especially when done by novice surgeons, that usually don't produce any sort of side effects. So is it possible? Yeah, okay. So which usually does not produce any side effects. Sometimes it may cause a minor amount of astigmatism. But it is because the smoothening of the flap is not complete in all directions that microstriae arise. So anyone who is doing refractive surgery for the first time, they may find that their amount of microstriae more. But more serious are the macrostriae that may happen as a result of flap displacement. And if it happens later, or if the flap has been displaced for a longer time, then epithelium starts growing over the bare stromal bed from where the flap has been displaced, and also forms, you know, a layer over the folds of the flap so that they become fixed. And now you have an extremely folded flap which is fixed and a layer of epithelium over the stroma. So when you're dealing with this, it is not impossible to deal with it. You can get very good results, but please remember that the epithelium needs to be removed in toto from both over the flap as well as the stroma. There should be no cells left around, and unless you remove the epithelium over the flap, you won't be able to straighten out the flap so that, you know, you don't have those undulations produced by the epithelium. And after straightening out that flap, after removing the epithelium, though there may be small striae in the Bowman's membrane, still the next day itself you'll see that you have a very smooth picture once the epithelium comes back. So this is one of the most important points of my session that I wanted to convey, especially regarding flap displacement. Now the second point was regarding, this is more like a lecture class, I guess. The second point was regarding epithelial ingrowth. So I have seen different types. Most of them are minor and they are to the edge of the flap where you don't need to do anything. But suppose they proliferate into the center of the flap and produce any sort of visual distortions in the visual axis, then you need to relift the flap. Don't wait. Once it has entered or is very near the visual axis, please relift the flap, and the epithelium needs to be taken off both from the undersurface of the flap as well as from the stroma completely. So complete peeling needs to be done, and then you would put in an inhibitor of epithelial growth like a little bit of alcohol, or more often mitomycin C, so that there is no further growth from the edges of the flap. And that is how epithelial ingrowth is to be dealt with. So these are some of the late complications that you can have. Ectasia has already been dealt with by Dr. Sujit. Coming to implantable colamer lenses, initially the injection of the lens is what is hard for the novice surgeon. That is because the injection needs to be done very slowly. There are people who sometimes flip the lens, and that usually happens because the injection is done fast and you're not seeing whether the leading haptic is moving in the correct direction. So that is very important that the injection be done slowly, and up to 5/6 of the lens, even if it comes out, you will always be able to turn your cartridge in such a manner that you can inject it properly. The second part is that all the haptics need to be tucked inside. There are 4 haptics. This is a plate haptic lens, and all of them need to be tucked inside. You cannot leave anything outside, because sometimes the pupil gives a false view. If it's a large pupil, then it gives a false view. Yeah, please do. It is complications of laser refractive surgery. I just want to show some videos. That's all. The first one. The PowerPoint there. Yeah. So now this is another unique complication that I had mentioned. So this was a person like Sujit's minus 2.5, and I thought it was cakewalk. I took the flap. This is one of my very early cases. And you can see once the flap is taken, the laser starts falling. But unfortunately, you can see there was some scanner error because of which all the spots fell in the center, and you see a deep pit over there. So this is very unusual, and though my laser was calibrated and maintained regularly, this happened. But the patient who had initial uncorrected visual acuity of 6/36 had a topography which showed extreme flattening in the center over there. And this is what happened by 1 month's time, when you can see that a coagulum filled up the gap. And the keratocytes came in and they, bridged it with collagen. So you had a slight haze over there, and his vision, thank God, was 6/9. So that is a lesson I learned. Now this is what I had talked about, but I think we have already discussed this, so I won't be going through it again. This is what I meant when you're taking off. The epithelium has to be scraped both from the stromal bed and from over the flap. So this is the epithelium being scraped from over the flap. And this kind of epithelial ingrowth is usually innocuous. Now this is an image of one of the things we used to have before the femtosecond laser came in. So you can see that you have a dehisced flap over here because the drape was preventing a proper flap dissection from taking place. Now such a flap needs to be repositioned, and you can do a surface procedure here. But still a scar remains. Now these are some of the femtosecond complications where you can have various types of bubbles. You can have innocuous bubbles that hinder pupil tracking, sometimes like this, or you can have air in the anterior chamber, which again would hinder pupil tracking a bit. So you can see how air escapes from the trabecular meshwork sometimes. This usually I've seen with thin flaps. So at least 100 microns is a good recommendation for a femtosecond flap. Then suction loss is also another complication that may be faced when you're doing a femto. You can see that the suction stops there. And then you need to take the patient out, maybe wait for some time before the bubbles clear, and then do again. So this was epithelial nest removal, which I think I explained verbally very well. So that is, can I have the other one? Yeah, that one.
You have to rush through because
Yeah, I will do
the
that.
time is 3:55. You have to stop, so you have to go fast.
Okay. So this is when you are injecting the ICL, it has to be very slow so that the orientation is proper. Now, when you have an untucked haptic, you can see a distortion like this in a small pupil. So that will make you aware, and you can, tuck in the haptic. But in a large pupil, it seems regular, but both the haptics are out there, down there. So that is the point I wanted to make. Then iris disturbances while washing the fluid can happen. So if you have an iris prolapse like that, then the first thing you need to do is dilate the pupil while irrigating. That helps a lot. It creates a channel so that you can push the visco out in a very harmless manner. So this is a Ured-Zevalia syndrome I had following ICL implantation, where the IOP was raised, the pupil was static, and even after 1 month, the pupil only recovered to that level. So overinflation of the anterior chamber can sometimes lead to that. This happens with some keratoplasty lamellar procedures also. Now rotation of the ICL usually never happens spontaneously. It may be post-traumatic, or initially you might not have placed the ICL well, where it needs to be re-rotated. So high vaulting ICLs are dangerous because they may induce glaucoma, a lot of pigment loss, wherein they need to be explanted. Then cataracts, we can do it with or without explantation of the ICL. And of course, retinal detachments, the chances are around 0.35 to 1.5%. Again, the ICL may or may not be retained. So, can I ask the chair's permission for 1 minute
Okay.
of... this is just to briefly describe one or two points about presbyopia management.
Okay, good afternoon everyone. Today, I'll be dealing with the topic of presbyopia correction, the present reality, a few options. So the presbyopia has everything, but nothing to do with age. Not only the age procedure, it can be done along with a routine cataract surgery, a pre-senile, or a complicated cataract, or with a pediatric cataract, or a refractive lens exchange corrected around the presbyopic age. So there are multiple options available. It can be a trifocal, it can be a continuous range of vision, EDOF lenses, enhanced monofocals, laser vision corrections options like Presbymax, Presbyon, presbyopic ICL, or a corneal inlay procedures like camera rings, raindrop, presbya, or a outdated scleral expansion bands. So if you are doing it as a routine IOL procedures, the prime importance is for the proper centration of the lens. So there should be a correct capsulorhexis regular with IOL inside all the rhexis margin, and the corneal Purkinje images, so that first image from the corneal plane and then from the lens plane should meet with the center of the lens. As seen in the vermeil, we can see that there should be proper centration of the lens. Now, when there is, in cases of an aged patient near presbyopic age of 38-year-old myope, where laser vision correction is not advisable, because if you are considering the case of a myope, there is a wide range of correction required. From a -2 range to a +3, there is a wide range of correction required, and there will be more induced aberration. And if ICL is also contraindicated with a small wide to wide or a low anterior chamber depth, or glaucomatous predisposed eye, we have to go for a lens exchange case. There should be prime importance in dealing with pediatric cataract and presbyopia. So when we are going, if you are putting a multifocal IOL in pediatric cataract, first of all the surgery should be done by a well-versed surgeon. So there should be a carefully we should take the anterior capsular flap. The prime important is if you are putting a multifocal IOL in one who is able to afford it, or in developmental cataract children already have a vision, some sort of vision, it's better to put a multifocal IOL. So there will be reduced amblyopia, and there will be increased attainment of stereopsis and binocularity post-op. So after a correct anterior capsulorhexis, we have to go with the nuclear matter and cortical matter, and we have to do a correct posterior capsulorhexis. And if things are happening correctly, we can go for a multifocal IOL, and this is better for reducing the amblyopia chances in pediatric age. Now coming to the enhanced monofocal, those where we can't go for a multifocal options, in DR cases and all, an enhanced monofocal is a better option with a higher order spherical surface, and a power gradually changes from periphery to the center. So it will give a good range of distant vision. Now coming to the laser vision corrections, the options are Presbymax, and here we are using a femtosecond, with the help of a femtosecond laser, we are raising a flap, and we are producing the excimer laser to create a central or a peripheral Presbymax. And other option is Presbyon. It's also a newer option, where one distant eye, dominant eye we are making distance and seeing for distance, and non-dominant eye for near vision with a blended zone. That will give a more compromised vision. And coming to the scleral expansion bands, so this is basically we are putting some scleral bands in the scleral area just above the ciliary process, and thereby creating more tension on the equatorial sonules, and thereby dealing with presbyopia. Other option is corneal inlays, can be camera, raindrop, or presbya. Basically this is giving an effect of pinhole vision. So with the help of we'll make a flap, but we won't raise that full flap. With the through a pocket, we will inject the camera ring inside. But nowadays it's not done because of the risk of extrusion of the implant and the corneal melt. Now recent advances like presbyopic ICL put forward by the Star Surgical's Evo Viva, it's known as Evo Viva, like a wide range of population is
conclude. You can just talk about this and conclude.
So like a wide range of population is waiting with a mild myopia and all, like they are waiting for a better option. This can change to be a better option for them. Thank you.
I would like to thank all my faculty and my discussants for being, and the audience for being tolerant. I'm very sorry about the glitches that happened during the presentation. Thank you so much.